All right, welcome. Let's talk about something we see every single day at the pharmacy, benign prostatic hyperplasia, or BPH. The goal here is simple, to arm you with the must-know counseling points for the most common meds you're dispensing. We're going to make these patient conversations way more effective. So let's just jump right in.
Here's how we'll break it down. We'll start with the big picture of BPH, then hit the two main drug classes, the fast-acting alpha blockers and the 5-ARIs, which actually shrink the prostate. Then we'll look at some common combos and wrap it all up with a super practical checklist you can use right at the counter.
So first things first, before we can even think about counseling on a specific drug, we've got to get a sense of what the patient is actually going through. BPH isn't a one-size-fits-all thing. There's specific symptoms. Are they going all the time? Is it a weak stream? That's what really shapes the treatment goals.
Now, you're not going to be formally diagnosing anyone, obviously, but it's helpful to know about the International Prostate Symptom Score, the IPSS. Think of it as a way to quantify how bad things are. A low score is mild, mid-range is moderate, and a high score is severe. Just having this framework in your head gives you a quick snapshot of the patient's situation right there at the pharmacy.
So what's the end game with these medications? Well, there are three main goals. Number one, and this is the big one for the patient, is just making them feel better, improving those symptoms. Number two, we want to stop the BPH from getting worse. And number three is all about preventing the really nasty long-term stuff. Keep these in mind because they explain why we choose certain drugs. Okay, let's get into our first drug class, the alpha blockers. These are truly the workhorses of BPH therapy. They're usually the first thing prescribed because, well, they work fast. They get in there and relax the muscle in the prostate and bladder, and patients feel relief pretty quickly.
Within this class, there's a really key trade-off you need to know about. On one hand, you have the non-uroselective agents, like doxazosin. These can drop blood pressure, so the critical counseling point is always take it at bedtime to avoid dizziness or even fainting. On the other hand, the uroselective ones, like tamsulosin, don't mess with blood pressure as much, but, and this is a big but, they have a much higher risk of sexual side effects. It's a conversation you need to be ready to have. Okay, stop and listen to this one. This is a huge safety alert for all alpha blockers, but we see it a lot with tamsulosin. It's called intraoperative floppy iris syndrome, or IFIS. It's a major complication during cataract surgery. The surgeon absolutely must know if their patient is on one of these drugs. This is a non-negotiable question you have to ask before dispensing.
So alpha blockers are great for relaxing the muscle, but they don't actually do anything about the size of the prostate. So what do you do for the guy whose prostate is just really big, where the size itself is the problem? Well, that leads us right into our next class of medication.
And that brings us to the 5-alpha reductase inhibitors, the 5-ARIs. If alpha blockers are the fast actors, these are the long game players. You have to tell patients this is not about quick relief. This is about playing the long game to physically shrink the prostate over several months. How they work is actually pretty straightforward. In the prostate, testosterone gets converted into something called DHT, which is like fuel for prostate growth. These drugs just block that conversion. DHT levels drop and the prostate slowly, gradually begins to shrink. It's a pretty clever mechanism.
Now, this number here, 50%, is unbelievably important. After about 6 months on a 5-ARI, a patient's PSA level will be cut in half. This is a massive counseling point because PSA is used to screen for prostate cancer. You have to make sure the patient knows that their doctor will need to mentally double any PSA result they get while on this drug. It can literally mask a cancer diagnosis if not handled correctly.
Okay, these are your absolute non-negotiable warnings for 5-ARIs. You have to manage their expectations. It's going to take a while to work. You need to mention the potential for sexual side effects and even mental health changes. But the most critical one, the absolute red flag, is the handling warning. A pregnant person must never handle a crushed or broken tablet because it can harm a male fetus.
Of course, in the real world, patients don't always fit into these neat little boxes, right? A lot of them are going to be on combination therapies, especially if their symptoms are really bad or they have other health issues going on. So let's look at the common pairings.
The alpha blocker plus a 5-ARI combo is a classic. It's like a 1-2 punch. You get immediate relief from the alpha blocker while you wait for the 5-ARI to start shrinking things. For guys who also have ED, adding tadalafil is a fantastic 2-for-1 solution. And if that overactive bladder feeling just won't quit, you might see an antimuscarinic added, but you have to warn them to watch for signs they can't urinate.
And speaking of tadalafil, I cannot stress this enough. This is a life or death counseling point.
Any PDE5 inhibitor is absolutely 100% contraindicated with nitrates like nitroglycerin. The combination can cause a catastrophic drop in blood pressure. You have to screen for nitrate use every single time.
Okay, let's pull this all together. Think of this as your final, practical checklist. These are the don't you dare forget points you need to hit when you're counseling any patient on BPH meds. First up, this is a huge one from the OTC aisle. Decongestants, like pseudoephedrine, are basically the enemy for a BPH patient. They do the exact opposite of what we want. They tighten everything up and can make their symptoms so much worse. You've got to give this warning.
I know we've said it before, but it is so critical it's worth saying again. Always ask about planned cataract surgery before dispensing an alpha blocker. Make this a reflex. Because of that floppy iris syndrome, this question can literally save a patient's sight. So here it is, your final 4-point mental check. 1. For those non-neuroselective alpha blockers, hammer home the bedtime dosing. 2. For 5-ARIs, preach patience and that critical handling warning. 3. For tadalafil, you're a nitrate detective every time. And 4. Remind them all that this isn't a cure. If they stop the meds, the symptoms will come right back.
And I'll leave you with this final thought. Newer research is starting to hint at a link between some BPH meds and a risk of heart failure, especially in older men. It really makes you think, doesn't it? As we're focused on helping our patients with their urinary symptoms, what's the hidden risk we're not seeing? It's a crucial question to keep in the back of your mind as you're providing care.